Welcome to the United Leukodystrophy presents Diagnosing Leukodystrophies with Dr. Bonkowsky from University of Utah and Dr. Bernard from Montreal Children's Hospital.
Good morning, everybody. I'm Josh Bonkowsky. I will go ahead and pull up a PowerPoint presentation to talk about some key aspects of diagnosing leukodystrophies. Let's make sure this all works. It's always exciting. Great. So just to rehash again, I'm Josh Bonkowsky. I'm a pediatric neurologist at the University of Utah, and I work at Primary Children's Hospital. And today we'll be talking about diagnosing leukodystrophies. So as a reminder, we think that there are about 1 in 7,000 live births of leukodystrophies. This is data back from in 2010. And there's more recent data suggesting that the incidence of leukodystrophies is even higher than we thought it was. So we have a publication coming out this year that it may be as high as 1 in 4,000 or 4,500 live births. So this is a lot higher than we think. As you all on this call are aware, leukodystrophies are severe diseases. Almost half of children will never learn to walk. It causes tremendous financial burdens on families and on the healthcare system. So almost $60 million in annual children's hospital charges just for leukodystrophy care for patients. And unfortunately, a fairly high mortality rate. So a 34% mortality rate by age 8. And, you know, kind of with sad news, there's a patient I just learned about this morning under our care that passed away. We wanted to extend our sadness for the family for the passing of their child. So there's a lot of challenges with leukodystrophies, and one of the big ones is with diagnosis. And so if you think about trying to diagnose somebody, there's some challenges, and one challenge is that the clinical features of a leukodystrophy aren't really different from one patient to the next. Different patients can have different presentations, but it's not a clear way to tell apart what their diagnosis is. Different disorders can have the same presentation. So you might have adrenoleukodystrophy, or you might have metachromatic leukodystrophy, but your presentation might be very much the same. And then with MRI, which is the kind of the gold standard for the first step in the diagnostic process, there's a few leukodystrophies that have characteristic patterns, but unfortunately many of them, the MRI features are very similar. Dr. Bernard, my colleague who'll be speaking next, will go through kind of the special features with MRIs, but at least for myself, it seems like it's a big challenge for how do you use MRI to make a diagnosis. So why is diagnosis important? Well, there's a lot of reasons. So the first thing is that for some leukodystrophies, there are treatments, and we want to make sure that we make that diagnosis as soon as we can. So if there is a treatment, that we get the child started on that treatment or the adult started on that treatment. The second thing is that there are, even if we can't have a cure or a treatment that really changes the disease course, there are therapies for children and adults with leukodystrophy. So there are things that can change how sick children get, or how often you're hospitalized, or how difficult life is. And we want to make sure that we take advantage of those therapies. So diagnosis really helps both with planning and with kind of the thought process around how we take care of people. Another big aspect is that if you can't see where you're going, it's really hard to plan for the future. And, you know, if you're thinking, am I looking at taking care of someone who has a month to live, or 5 years to live, or 30 years to live, it really changes your thought process for how you plan day to day, and your financial planning, and how you work with the other kids in your family. It's important if you are hoping to have other kids, or how you interact with the kids already in your family with, you know, trying to take care of a child who's affected with a leukodystrophy. Another big aspect is that for clinical trials, many of which are happening more and more in leukodystrophies, a diagnosis needs to be known to enter the clinical trial, and so that diagnosis is important for that. And then finally, there's a lot of stress or anxiety about not knowing what's going on, and just having a name for disorder really gives the face of the enemy, really gives the enemy a face in these conditions, and knowing what you're battling against, I think, is really helpful. So there are some questions that are helpful when we think as clinicians about how to make a diagnosis. One question is the disease what we call static, meaning not changing a lot, or is it progressive? And usually when we think of progressive, we mean getting worse. Another big question is the onset of symptoms all of a sudden? Is it acute, or is it kind of happening slowly? And then a third big question is there some other explanation? So is there some other medical explanation for why the white matter looks abnormal? So things like infection or hypoxic ischemic injury around the time of birth sometimes suggest that we're not dealing with a leukodystrophy. So these are important considerations when we think about diagnosis. So in general, for the first step in diagnosis, after the clinical exam and history, an MRI picture of the brain is almost always preferable to CT at some point. Even if a CT is the first step, folks definitely need a brain MRI picture. There are times when clinical characteristics can really point us in a certain direction, although I can say I have been fooled multiple times by clinical characteristics, including just a few months ago. And so I had my humble pie, and don't let the clinical characteristics completely fool you. A third thing is that there are specialists in the country and across the world who'd be really happy to work with you or your family if diagnosis is challenging. I don't want to suggest doctor shopping, but reaching out to people for help, forming a team to help make a diagnosis is a good idea. So if we think about a leukodystrophy, how do we think of it? Like, what is a leukodystrophy? So first of all, it should be caused by a genetic disorder, so a change or mutation in a gene. And then there's basically three kind of ways to think about a leukodystrophy. So one is where there's hypomyelination, so less myelin, less white matter than normal. The second aspect is a dysmyelination, where white matter forms, but it's abnormal or not working correctly. And a third form or type is demyelination, where there's myelin to begin with, but it gets lost. And so sometimes people can have combinations of these symptoms or patterns, but these are kind of the basic pathological features of what a leukodystrophy is. So one of the big aspects in diagnosis is making sure we're not barking up the wrong tree. So there's been a lot of discussion or debate in the field about the terminology, and it really is more of a semantics question. So people sometimes use the word leukodystrophy or leukoencephalopathy or genetic disease of the white matter. I think most of the time, most of us are talking about the same thing, where we're talking about a genetic disease that affects the white matter. However, there are conditions that aren't genetic diseases of the white matter, that aren't leukodystrophies, or where we could make a diagnosis with genetic testing. So things like traumatic injury to the brain, if someone's had a stroke or meningitis, certain medications even can cause white matter changes. And so there's a list of things that your clinician or your physician should be thinking about as they consider whether or not you might be affected by a leukodystrophy. So there's kind of a classical approach to diagnosis. And that classical approach, which has important features, one is, of course, to take a good history and meet the patient. A first step, as I mentioned before, is that we do want to get a brain MRI. And sometimes the MRI can lead us in a certain direction and help us with diagnosis. And then based on the technology that we've had, it used to be that we just had to kind of slowly march through sequential testing, meaning one test after another, either biochemical and or genetic testing. And this was kind of our classical approach to testing. So this next slide is a little bit complicated, so don't fear, but basically there's data out now that the classical approach to testing, although it was the best we had at the time, is relatively inefficient. So on the right-hand side of your screen is a algorithm that was developed in the early 2000s for using MRI. And at that time, MRI was one of our best options for diagnosis, but you can see it's highly complicated and really relied upon having a good, someone with like, world-class skills for MRI interpretation. And so I think that was a difficult way to make diagnosis. On the left-hand side are two pictures showing how much it would cost to try and make a diagnosis. And I don't know if we can see the mouse here on the screen. Hopefully you can see the cursor. But this top panel shows that with kind of the classical approach to testing, that our diagnosis rate would kind of peak around 30%, meaning we could only diagnose around 30% of patients. and that as we did more and more tests, that this shows the number of tests that we'd send on a patient, that of course we would be sending more and more tests, our costs would be going up, and we would not be making more diagnoses. The bottom picture shows, based on how many tests, how likely it was that we could get a right answer, with green being good. And you could see that usually in our first couple of tests that we ordered, we were most likely to get a diagnosis. As we sent more and more tests, we just got more and more unlikely to make a diagnosis. And so this was kind of the technology in the early 2000s up till even maybe the past 5 years. While it was kind of our best approach, it had a lot of limitations. Another aspect that's been real important is try to understand how many genes are out there for leukodystrophies. So back in 2015, a very nice group of experts in the field got together and defined what they termed the kind of 30 core leukodystrophy genes, and then another 61 genes that they termed leukoencephalopathies, so trying to differentiate them slightly. This was a great kind of start for understanding the different causes of leukodystrophies, but as we know now, it's clear that there are not only 91 genes causing leukodystrophies. So back then and even now, there are many patients with clearly genetic diseases, with white matter disease, who remain undiagnosed, who don't have one of these 91 genes mutated. I'd say almost week to week or month to month, we're finding new genes that causes leukodystrophy, so this 91 has to be updated. And then there's not really those 30 genes that were considered a classical leukodystrophy are really different in terms of their biological function and biochemical function. So it's a little confusing to think why are these genes the ones that cause leukodystrophies. So it's pretty clear now that there's a lot more genes that can cause white matter changes. And so there's a paper coming out this year that the number of genes is clearly in the hundreds. This group, of which I helped lead the effort, thinks there's at least almost 600 genes that can cause white matter disorders that are genetic. So really, there's a lot of diseases out there that cause changes in the white matter. So I guess the big message there is that there's a lot of genes causing leukodystrophies, and just knowing that they're out there, I think hopefully will help people improve their rates of diagnosis. Another big thing I wanted to talk about, which I think is really appropriate given the turmoil that's been affecting the United States the past few weeks, is trying to understand the diagnosis of leukodystrophies in minority patients. And so when I thought about the work that I've done and the work that many of our colleagues have done, most of our studies have really focused on first world countries, so like the United States or Europe. And so we don't have a very good understanding on leukodystrophies in people from other countries or from other racial or ethnic backgrounds. And we're not certain if we're missing entire categories of leukodystrophies, or if we're diagnosing and treating these kids appropriately. So we did a big survey, like a big data analysis in a data set from something called PHIS, or the PHAS, which is data from the Children's Hospital Association, which is 50 children's hospitals in the United States, and just looked at the number of leukodystrophy diagnoses across the United States in children from different racial and ethnic backgrounds. And so we were somewhat shocked to see that the rates of leukodystrophies are 30 to 50% lower in some racial or ethnic groups. So the red arrow here points to the white, non-Hispanic, Caucasian population. So this is kind of the rate in the hospitalized children's group. You can see here that if you're Black, non-Hispanic, that's down here, or Black Hispanic, or white Hispanic, that the rates are a half or a third as high as they are in white Caucasian patients. So a lot lower rates. So one possibility is that, of course, that there's socioeconomic factors affecting the rates of diagnosis. Another possibility is that there's something called a founder effect, which means that maybe there are genetic differences in different kinds of leukodystrophies in people from different racial or ethnic backgrounds. So to rule out that as a racial or ethnic problems, to rule out that as what's called a founder effect, meaning that there's different rates in different racial or ethnic backgrounds, we looked at this kind of complicated database called the NOMAD database, which records the number of mutations for different diseases. And we looked for a founder effect. We looked at 4 different genes because it's difficult actually to look at the other genes for a variety of reasons. And in fact, the rates of these mutations are the same or higher from Latino or African American populations. And so in fact, if anything, we should be seeing higher rates of leukodystrophies in children from Hispanic or African American families, which is the opposite of what we see. So I guess the big message I think for us as clinicians and providers and as an organization is that we're really doing a disservice to our to other folks in our communities with an underdiagnosis of leukodystrophies. And it really suggests that it's more of a socioeconomic problem or a bias problem as opposed to some sort of genetic difference in rates of leukodystrophies. Another way to look at this data is to look at maps of diagnosis rates in the United States. And so this is a kind of a reverse heat map showing rates of either high diagnosis, which are kind of the red spots, or rates of low diagnosis, which are the blue or dark blue spots. And so there's different places in the United States which have either slightly higher rates than average of diagnosis or lower rates than average of diagnosis. One interesting point is that if you live close to a specialist, which are these little tiny blue squares, I don't know if you can see that on your screen. If you live closer to one of these specialty centers, then you're more likely to get a diagnosis, just I guess emphasizing the point that specialists in leukodystrophies are helpful for making that diagnosis. So that's a lot of information, but even with all this best technology, we are really struggling to get diagnosis rates above 60%, maybe 70%, even using this technology called next generation sequencing. So there's different kinds of sequencing testing, and hopefully I won't put the audience to sleep, but the 3 big tests that are kind of floating around right now, one is called whole genome, one is called whole exome, and the third is targeted sequencing. There's also something called panel sequencing. And so whole genome basically looks at every single bit of DNA. Whole exome covers what are called the coding parts, the protein parts of your chromosomes in DNA. And then targeted or panel sequencing looks at just the genes we think are involved in certain conditions. It used to be that none of the technologies on this slide were available. So 5 years ago, none of these were choices to get clinically. Now all of them are choices to get clinically. The big problem is insurance coverage and access to testing. I'd say that now half or more of insurances are covering whole exome. We rarely get coverage for whole genome. Occasionally we do. The thing that's important about whole genome is that the technology and the costs have come way down, and the revolution that that's causing is going to continue, I'd say, in the next 5 or 10 years as well. So the first human genome cost $2.7 billion. So that's billion with a B. It took about 13 years just to do one person. Now you can get rapid whole genome sequencing clinically in 3 days for $12,500. And this technology is continuing to shift quickly. So we're kind of at this inflection point right here. There is kind of next generation sequencing technologies that are going to continue to transform our ability to make diagnoses. So if you look at, if you want to think about like, what does that mean, practically, this is what 23andMe gives you back. So this is if your DNA was represented by a book, you would get about 180 pages worth of a book. If you did your whole genome, you would get the entire book. You get 4,200 books. So you basically get a library back of information. So don't do 23andMe. Okay, so what's the answer? So I've talked a bunch. Now let's just get down to the answer. So really, you want to do 2 things. The first is there's a few leukodystrophies that are time sensitive that you need to make the diagnosis quickly, and you want to make that diagnosis fast. And so those 2 tests basically are leukocyte lysosomal enzymes and very long chain fatty acids. Or if you have access to a rapid exome or rapid genome, that'd be fine also. But basically, you want to be getting an answer in 1 to 2 weeks. And those first two things, the leukocyte lysosomal enzymes, the very long chain fatty acids, usually you don't need insurance pre-authorization for. Usually you can get it done and the results back in a week or less. Once you've done that test, you have more or less covered treatable disorders, and now you're kind of going to the next step. And the next step, based on cost, based on how long it takes, and based on the likelihood of finding an answer, you should be using next generation sequencing, which more and more is whole exome or whole genome, or still in some cases, a leukodystrophy gene panel. That's what you should do. Like, don't mess around, don't do other stuff, like just do this. Now, the big caveat is even this is like the most advanced testing there is. Even with this most advanced testing with the best labs, the diagnosis rate is still 50 to 70%. So on the one hand, that's great. You're like, I'm so happy. In half the cases we find an answer. On the other hand, that means 30 to 50% of the time we're not finding an answer. And it's really unclear who or what is going on for that other 30 to 50%. So it's still a challenge even in the best of cases. So if you fall in that 30 to 50%, you are not alone. It is super frustrating for everybody. And it's a big area that everyone's trying to figure out, like, how can we improve the diagnosis rates? So, some people, I guess insurance companies sometimes argue back saying that, it costs more to do these advanced next generation sequencing tests. But the data is the opposite, that if you just go to smart diagnosis, faster, that you're saving lots of money. So you shouldn't be messing around. So there's data out there published showing that these advanced tests are money savers, they're cost effective, and they're more effective for the patients. And I thank you all for your attention. I'm happy to take questions now, or I don't know if we would prefer to wait and do it at the end after Dr. Bernard has also given her presentation.
Okay, my turn. Hello, everybody. So I'm Genevieve Bernard. I'm an associate professor at McGill University and a clinician scientist. And I will give you a little bit more information about MRI. Okay, I hope you're hearing me well. I'm not sure how to change my slide like this. 1 second. One second. Okay, so my slides change here, but they don't change on my other screen. Sorry about the technical problems. Okay, I think it should be working now. Okay, it works. Sorry about that. So these are my disclosure. None of the disclosure I have on my slide have anything to do with what I'm going to present today. So a little word, I'm sorry, I do this from home, and I have 3 kids and a dog, so we may be interrupted. Okay, so a few words about myelin. So you may all know that already, but just to make sure that we all understand each other. So myelin is the white area here. I hope you see my arrow in the brain, and the cortex, which is the gray area all around, is the gray matter. And so you can see a neuron like an electric wire, where you have the plug that you put in the wall, which is the cell body of the neuron, and it's actually here in the cortex. And then you can see the axon, which is the electric wire itself, which is protected by myelin. And this myelin does the same as an electric wire. It protects the axon and allows for fast electric conduction in the axon through the arms and legs. And so all of these cell bodies are in the cortex, and the axon goes down to the brainstem and then to the spinal cord, to your arms and legs, and that's how you can move. So you can imagine that if you have a myelin problem, then it does have an effect on the conduction of the activity of the neurons because it slows it down, but it also unprotect the axon and make the neuron die. The cells that are producing the myelin in the brain are called oligodendrocytes, and one oligodendrocytes during development extend their processes to wrap around the axons of multiple different axons. So when one oligodendrocyte is sick, it removes the myelin from several different axons. So Dr. Bonkowsky touched on this. There will be some repetition between the two talks, but I think sometimes it's nice to hear things twice. So a leukoencephalopathy is any disorders that affect the white matter. It could be acquired, such as multiple sclerosis, or genetics, such as the leukodystrophies. We like to differentiate leukodystrophies from genetically determined leukoencephalopathies. So the leukodystrophies are genetic disorders that we think affect primarily the cerebral white matter. And the distinction is important because if you're dealing with a leukodystrophy, the MRI signature or pattern recognition is usually pretty classic and easy to and easy to apply and have a good idea of what the diagnosis is. Genetically determined leukoencephalopathies are all the other disorders that lead to abnormal white matter. And in this category, the MRI pattern recognition is not as precise. So we're going to go through MRI 101. So when we do a scan of the brain, we basically cut the brain in different directions. In that way, we can have different pictures of the brain. So and the way we cut the brains actually are called in different sequences. So if we do axial cuts, we cut like this. If we do sagittal cut, that's an axial cut. If we do sagittal cut, then we cut in the middle of the brain, and we do slice like this, all the way through the brain. Sagittal all the way to the brain like this, and then coronal cuts are perpendicular to both of them. So then we do cuts all the way like this. So when we look at the brains in the different sections, so if you do a sagittal cut, where you cut in the middle of the head, you can see here the nose, the mouth, the tongue, and then you see the brain. And when we look at sagittal cut, basically it gives you an idea of this is the brainstem. The brainstem is the region that where all of the wires pass to actually goes into the arms and legs. So we can have a good look at how the brainstem is and have an idea whether or not it's too small, or if there's a malformation, or if there's white matter abnormality on the brainstem. And this is a normal brainstem. We can also look at the cerebellum, which is a structure behind the brain that's responsible for different things, but including balance and coordination of movement. We can also look at a structure in the middle called the corpus callosum. And so this structure is the structure that where most of the fibers goes from one side of the brain to the other side of the brain. And that's really important because the two sides of the brain have to speak to each other in order for you, for example, to clap your hands, so that both ends know where the other end is, and yet that way you can clap your hand. So we can also look at the corpus callosum because some disorders are, like a smaller corpus callosum or a progressively smaller corpus callosum. This is a coronal cut. So we cut in the middle of the brain like this, and then you can see the ears here, and you can see the cortex all around it and the white matter. And this is the brainstem, which is this structure, but cut in the middle like that. And then this is Whoops, sorry. Okay, this is a coronal section, and this is an axial section. So then this way we cut the brain like this, and then you see the eyes and are here, the nose are here. You see the brain stem, which is cut here, and then you see the rest of the brain, and you can even see a little bit of the cerebellum. So the cut was something like this here. And then when we look at the MRI, we look at different sequences. So the sequences are basically made, so the MRI is a big magnet, and if you change the physics of how you acquire the sequence, you have different colors, different tones of gray and white, and that is helpful to differentiate one disorders from to identify the actual lesions and characterize them. So a T1 is like anatomy. So the gray matter all around here is gray, and the white matter is white. If you look at T2, so in the T2, it's usually easier to see white matter disorders. It's usually more obvious, and it's universally abnormal when you have a white matter disease. So here it's the reverse. The white matter is dark gray, and the gray matter is light gray. And then there's another sequence that we often use. It's FLAIR, because a FLAIR is basically a T2. Look, the white matter is dark and the gray matter is light gray. But there's you remove the white of the CSF, the cerebrospinal fluid, which is basically like water. So on T1 it's black, on T2 it's white. But if you can imagine that there's a lot of white matter disease, then the whole black here becomes white, and it becomes difficult to differentiate what's the CSF, so what's water and what's brain. So in this specific sequence, as you can see, everything looks like T2, but the CSF is black. So it helps us understand whether or not there is a cyst, if there's some water in the white matter, or if there's a loss of white matter and it's replaced by fluid, or if it's actually a white matter disease without a loss of white matter. But we use numerous other sequences to help us diagnose the leukodystrophies. So leukodystrophies are there's two main categories of leukodystrophies. There's the hypomyelinating leukodystrophies, which are developmental disorder, where you don't have enough myelin deposition in the brain, and you have a permanent decrease in white matter compared to what you should have. And all of the other disorders are categorized together as other myelin pathologies. And these include, for example, metabolic diseases, also other disorders of vascular disorders and things like that. So you've seen this is a paper that had that was published by Dr. Schiffman and Van der Knaap on the classifications of leukodystrophies and on MRI pattern recognition. So it's basically how on MRI you differentiate between hypomyelination and all other pathologies. So if we look at images, so this is a normal MRI. So as you can see, white matter is white on T1, gray matter is gray. And then when you look at the T2, the white matter is dark and the gray matter is light. But then if you look at the other pathologies or a demyelinating leukodystrophy, then you see the white matter on T1 is black instead of being white. And on T2, it's bright white, okay, compared to black. And then if you look at hypomyelination, then the white matter is almost normal on T1, okay? And on T2, it's white, but it's not as white as when you look at other pathology. So this is the first thing we look when we look at an MRI is this. Wow, like how are we going to categorize the disorder? Because then after that we apply other criteria to diagnose which one we think it is. But it's a little bit more complicated than that, because especially in younger kids, because when you're born, you have almost no myelin in your brain. So myelination starts when the mother is pregnant in utero and progress until adulthood. But around 2 years of age, the myelination is almost complete. And then knowing so we know how myelination occurs, and that helps us analyze the MRI of these younger kids. So we know that the myelination starts from bottom to top, from the center of the brain outside, and then from the back to the front. So we cannot talk about MRI pattern recognition without acknowledging all of the work that was done by Mario Vanknapp. She's been describing new disorders based on MRI pattern recognition way before next generation sequencing happened, and discovered genes by grouping patients together that had similar MRI pattern. And MRI pattern recognition is very helpful for diagnosing leukodystrophies, but also to be able to describe new disorders. So this is the same paper Dr. Bonkowsky showed before, and then the same in the same paper I just alluded to earlier. So basically you have, it's small, I know, and I won't make you neuroradiologist, but the MRI characteristic, then you decide whether or not it's in the hypomyelination category or in the other category. And then after that, you decide if it's more in the front, you have a list of disorder it can be. If it's in the middle of the brain, you have a list of disorders like it could be, and so on and so forth. But since that was published in 2009, since then, there's a lot of disorders that have been described, and this algorithm has become much more complex. So I just thought I would give you example. So these are 2 MRIs of patients with hypomyelination, and I hope it's that you see that these 2 pictures are different. In this picture, the white matter, I put you normal here, should be black, right? Because it's a T2, it should be black, and it's diffusely like white, but not as bright white as we've seen before in the first MRI that I showed you. So this is hypomyelination. It's diffusely abnormal. It's very homogeneous. And so this patient has Pelizaeus-Merzbacher disease. In this MRI, you also see diffuse lack of myelin, so all the white, but you see nice areas where you have normal white matter, so the black. So we see white matter here, which are the optic radiation. So this is the structures that make what your eyes see go to the part of the brain that make you understand the image. Also, this region, which is called the anterolateral nucleus of the thalamus, and the globus pallidus. So very specific structures are preserved. When we see this MRI, it's I don't think I've ever seen this MRI in another disorder than 4H or pollard 3 related leukodystrophy. These are only 2 examples. I could give you much more, but it's just for you to understand the concept of MRI pattern recognition and how we do this. And then I thought I would show you a few 3 MRIs of the other disorders, the demyelinating disorders. And so I hope you can see that these 3 MRIs are different. So in this first MRI here, the white matter is, all of these 3 MRIs, the white matter is bright white, the part that is abnormal. So this is all the other disorders. So now you're switching to the other category, and that helps you. So it cannot be Pelizaeus-Merzbacher because it's not. We've seen the MRI before. It cannot be pollard 3 related leukodystrophy because the MRI is way too bright on T2. So in this specific MRI, so you see there's an involvement of the structures, which is called the corpus callosum. There's involvement of the white matter, and then there's some normal white matter here, just close to the cortex. And perhaps it's hard for you to see on the slides, but there are little lines in the white matter that are black. So this is a very, very classic MRI for metachromatic leukodystrophy. This MRI, if you look carefully, the frontal lobes are more involved than the posterior part of the brain. Okay? There's little you know how this structure, which is the frontal horn of the lateral ventricle, is very nicely round here, but it's abnormal in this here. And then when we give contrast, this is going to light up. And the other thing that this patient has is these structures here, which we call the basal ganglia, are not as nice as this patient here, for example. The other thing that this patient has is a rim around the ventricle that is black, which you don't see here, which you don't see there, and that you don't see in any other disorder. So this is Alexander's disease. And this last picture, the frontal white matter, all the front of the brain, you know, the white matter is nice, it's dark, but it's the posterior white matter that is abnormal. And if you were to give contrast to this patient, you would have a rim of enhancement of just all around the lesion here. And so this is adrenal leukodystrophy. So I wanted to also say, briefly touch on MRI, on the clinical characteristics. So in general, leukodystrophies present similarly in different age groups. So if you have a baby presenting with leukodystrophy, whatever the leukodystrophy is, the babies really sometimes will really look very similar. If you have a toddler or a child, again, the presentation is very similar. If you have an adolescent or an adult, they have specific presentation. So it's really more by age group that the presentation change, but you can have clues into which disorder you could consider. For example, and these are not the exhaustive list, they're just examples. So if you have teeth abnormalities, so you can have, for example, missing teeth, a baby born with a tooth at birth, smaller teeth than normal, and this you can see commonly with polaroid 3 related leukodystrophy. You can have a kid who has a lot of propensity to have cavity, and so this you can see with cocaine, for example. And then endocrine abnormalities. So polaroid 3 related leukodystrophy, for example, commonly have delayed puberty or absence of puberty. Some of these kids have growth hormone deficiencies. If you think about vanishing white matter disease, for example, they can have ovarian failure, Aicardi-Gouttière syndrome, can have hypothyroidism. So if you look at, for example, you have a child with hypomyelination and also malformation of the hands and feet, then you can think about oculodental digital dysplasia. Skin lesions are seen in some disorders. So Aicardi-Gouttière have Chilblain lesions or other rashes that are very typical for this disorder. And cocaine patients, for example, typically have hypersensitivity to sunlight. Patients with big heads can also give you a clue. So macrocephaly is seen in Alexander's disease, in Canavan, and in megalencephalic leukoencephalopathy with subcortical cysts. So there are many other examples of clinical clues that the clinicians can use to make diagnosis, but usually the MRI is more specific for the disorder. So I thank you very much for your attention, and and if you have any questions, don't hesitate to ask. I just want to acknowledge all the patients and families that are participating into our research, my research team and collaborators, and over the years, the funding that we have for working on leukodystrophies. Thank you.
Very nice, Dr. Bernard. And Tara, are there, I see there's many questions that have been added on this screen here. Did you want to moderate some of them for us?
So perhaps we need to read the questions and try to answer. Oopsie. Okay. So I'll start from the top. Do you have any data on the financial impact on families? Josh, I think you'd be better to answer that question.
We don't have any data on the direct impact on families. We know we've seen the cost of leukodystrophies, and so for all the kids in the United States, the yearly costs are $60 million a year, and then that's a lot for all the kids. But then if you think about an individual family, there's a big range running from, if you think about a 10-year time span, running from something in the $3,000 range to families that have more than $1 million in costs. And I think the high dollar costs are families which are getting transplants. But we only know the charges. We don't know how much is covered by insurance. I don't really have any data to know how big of a direct, impact on people's checkbooks it is. We know, I guess, from kind of personal experience, and Dr. Bernard, you can also comment that for families, it does seem like there's a lot of stress and challenge with both the diagnosis part and travel and medical care costs that we see in other ways, like higher divorce rates and just more stress in the families. So it seems like there's both financial and kind of personal impacts on families.
It's also common that one of the parents have to stop working, or like in certain families where more wealthy families that can afford having someone at home full time, but that's also a significant cost. So there is certainly an impact on the families in terms of expenses, either by one parent staying at home or by hiring help to deal with the daily life with a child with leukodystrophy.
That's a very good point. The next two questions look like they're questions about, one question is about data on moms who went through infertility treatments. And the second question is if there's any link with C-sections or induced pregnancies. And Genevieve, do you want to answer either of those questions?
To my knowledge, there's no data on fertility and the risk of having leukodystrophy. I would think, though, that if the family is at risk for having a leukodystrophy that has the potential to have a very serious and early onset in utero and had multiple abortion, that this could be actually not making the risk more important, but just a sign that there has been previously affected children. I know that there are impact of fertilities in different developmental skills, and I think there are some impact, but not to causing a leukodystrophy. And C-section does not make a person more at risk to have leukodystrophies. It makes the person, if there is fetal distress and there's significant anoxia, so missing oxygen to the brain, you can have lesions in the brain. It could be in the white matter, especially in premature babies, and we call that periventricular leukoencephalopathy. PVL, periventricular leukoencephalopathy, and so yeah. Do you have anything to add, Dr. Bonkowsky?
No, I mean, I've worried a little bit about whether in vitro fertilization, we've seen a couple kids with Krabbe or Canavan disease, but I think that might just be personal bias, or not bias, but I don't know if there's any true statistical significance to that. So I think that's an important question that someone should look at. The next question.
It was in vitro and the parents were not carrier?
So I think we had trouble getting the parents tested. So I don't know the answer.
Because you wonder whether, if you have in vitro fertilization because you have difficulty to conceive with a severe disease like Krabbe, whether or not it's not part of why you have difficulty conceiving. And then if you do an in vitro fertilization, then you have a child affected. But I would think that the parents would be carriers.
That's a good point. Yeah, I don't think it's causing the mutation, but whether there's some sort of weird selection bias with the harvest or something like that, but don't really know. The next question we have is, we have a diagnosis. Is it important to get genetic testing as well?
Yes.
Yes. So presumably they have some sort of diagnosis from MRI, but the question is, and so why should they get genetic testing, Dr. Bernard? What would you say?
To confirm that this is the actual diagnosis. That's going to help predict the future in terms of availability of treatments, if there are, or if there, because there will be treatment for some of these disorders in the coming years, and also for genetic counseling. So the family and extended family needs to have information about the disorder and how it's transmitted, and whether or not they're at risk to have a child with the same disease, so that they can make reproductive decisions.
Yeah, I think that's totally agree with those points. Next question asks whether the we presented some data on the diagnosis rate being higher near expert centers, and the question is it because they are better at diagnosing, or because there's higher needs in the community or in that region? And I would think that it's much more that the centers are better at diagnosis, and that's why they're making more diagnoses. And so there's not the making a diagnosis. It takes some like the information we presented today is we try to make it understandable and straightforward, but it took some years of work and study to figure out how to do these things. And I think that there's not special diseases here in Utah or Canada or near Philadelphia where rates are higher. It's that there's Dr. Bernard or myself or Dr. Vandiver or Dr. Vanderknapp or Dr. Eichler who are making these diagnoses because they know how to do it. So I think it's much more these specialists who are good at diagnosis. And Dr. Bernard, you made a comment about assessed in person via telemedicine. Could you explain that? Do you have a thought about that?
I get lots of emails from families around the world, especially because we work mostly on hypomyelination, and so we meet with the families online. We organize a Zoom meeting and we discuss with them, and we've been helping families with dealing with their disease, and the clinicians. We've been answering questions to clinicians, and I think I know Dr. Vandiver does that too. I know when I have questions, I reach out for if I have a question about ALD, I reach out to Dr. Eckler's, to Dr. Fatimi, to Dr. Raymond. So I think between each other, we answer each other's question according to which diseases we work most. But we also get calls from clinicians around the world for help, and also sometimes from families.
And then we have a question: is the low diagnosis rate with smart diagnosis due to a number of disorders that are not being described? So I'll start that one, and then Dr. Bernard, you can pick that up. So the diagnosis rate, kind of the best published diagnosis rates are about 70%. I'd say that most places are hovering closer to 50, so somewhere in the 50 to 70% range. So that's not terrible, right? That's not. We wish it were 100%, but a 50 to 70% diagnosis rate is pretty good, especially compared to what it used to be. But like the person's asking, what's going on with that other 30%? And I feel like it's a combination of things. One thing is that we don't know all the disorders that cause leukodystrophies. The other thing is I think there's some biology that we don't understand with leukodystrophies. Dr. Bernard, do you have other things for that?
So I wasn't sure I understood the question. So I think the rate of undiagnosed with next generation sequencing is, if you look at there are two main papers. One was done by Dr. Van der Veer, it was around 30%, and one was done by Michael Van der Knapp, it was around 20%. I think it's something around 20 to 40%, depending of whether or not you consider a strong gene candidate that hasn't been proven as being disease causing or not. But I think there are different reasons why people are not diagnosed. Either they don't have access to sequencing. That's one reason. It could be also that it's a new disease that hasn't been described yet. And that is something we work on. Dr. Van der Veer works on. There's several people working on describing new diseases. And the difficulties we have now is that most disorders that are rare, but common rare, if you want, have been described. But the disorders we're left with are ultra rare diseases. So it takes us often years to get. So we have one patient, and we're convinced we have the right gene, but we can't be certain before we have other patients. And sometimes it takes years before we get the second, the third, and the fourth patients. So that's, I think, an issue. And the last thing that could be an issue is having an atypical presentation for a known disorder that we didn't know about. And when you're the first person getting this, they call this a variant of unknown significance. So meaning you have an error in a gene, but you don't know what it caused. Then you can't have a diagnosis until it's been published that there are other patients that look like you, but that have the same mutations in the same genes. And I think these are the main reasons. The last reason that we should not forget about is that some patients are misdiagnosed as being leukodystrophies, but probably have an acquired disease, an in utero infection, for example. And so this also is part of the reason why some patients don't get diagnosed, I think.
Great. We have just a few minutes left. A question here, is it possible to have more than one kind of leukodystrophy? Dr. Bernard, any?
Yes, it's rare, but it does happen. We have a few patients that have more than one disease. It's rare that it's two leukodystrophies, but I have a patient with a mitochondrial leukodystrophy and a metabolic disease that could lead to a leukodystrophy as well. So we do have patients with two diagnoses.
The next question asks about telehealth and insurance companies, and about the need to examine in person. And so I might make a comment here. So in this era of COVID, it's been very helpful in the United States to have telehealth in place, and we've done lots of work seeing patients. It's not the same as being seen in person. So if possible, being seen in person is better, but it is better than not seeing a specialist. However, and this is where you need to reach out to your representatives. Both insurance companies and state medical boards are removing these emergency leeway that was giving, and so now it's become that you can only see patients in the state that you're local to license. So, for example, I can't see a patient who lives in Montana, even though there's no other pediatric neurologist, for 500 miles, and so that patient either has to travel here for 500 miles, or we can't see them and they can't use telehealth. And so it's just the country needs to figure out a better way to provide care for kids. And we have telehealth, like we should use it. So we have a last question here. Do people with chronic migraines have myelin loss?
This is a hard one. It's been described that patients with migraine have white matter abnormalities on the MRI. I am skeptical about that.
Yeah, I think we've both kind of seen these papers of like white matter abnormalities, kind of scattered white matter abnormalities, but never any real suggestion that they have a leukoencephalopathy or something like that.
There are disorders where patients have migraines, and migraines is part of their presentation of a leukodystrophy as well. So it always depends what the MRI pattern looks like, and what the evolution is as well.
And I see we've received a threatening note from the ULF telling us to stop talking. We'd like to thank everybody for attending this session. Thanks, Dr. Bernard. Thanks, Josh. Have a good day.
Thank you for having us. I hope you liked the talk. Bye.